Welcome to this episode of Compliance Deconstructed, brought to you by Simply Compliance and your wonderful co-hosts, Elvan Baker and Jessica Zeff. Lori is on hiatus today, but we brought in a rescue mission. We have a gentleman named Marwan, and Marwan, I'm a horrible human being because I didn't write down your last name. So Marwan, what's your last name?
My name is Marwan Kanafani.
Thank you so much.
Of course.
I knew I was going to do that. I even told myself before the podcast, write down his name so that you say it. And of course, what was the last thing I didn't do?
Is it allowed to ask what's the ethnicity?
Yeah. What's it's a Lebanese name. So I'm half Lebanese and half Korean.
Ooh, there we go.
That's an interesting mixture.
Yeah.
Okay, we're going to get there. We can talk about that sometime, maybe not on the podcast, folks. But all that said and done, Marwan is a guest today on our episode. Really appreciate you being here, even if I'm a toad, Marwan. I'm so sorry, but I really appreciate you being here. Marwan's going to help us out with the discussion around the California Medicaid program. It's a huge program. It's very complex, and we don't often get that kind of expertise to give us some insight about how the program works. So with that said, Marwan, can I ask you, first of all, to introduce yourself?
Sure. Well, thank you so much for having me. Compliance Deconstructed is on my top podcast list, so I've been such a fan.
We don't pay people to say that.
No, I promise. No.
Not this time. We've done it in the past, just not this time. Go on.
Well, so I've been in managed care for over 10 years, all California, mostly on the plan side. I studied at Boston University and got a business degree and a public health degree. And I didn't know I was going to go into insurance. I mean, I don't know if this was the case for you all, but not very many people as little kids say, hey, what do you want to be when you grow up? I want to work in managed care. It's something that kind of comes along as you've been studying more and more about healthcare. And so I got attracted to that when I was in Boston, coming back to California and working in health insurance. And it's been a really great ride. Commercial, Medicare, Medi-Cal, which is the kind of brand name of the state Medicaid program in California. And then I've recently started my own technology company to build in compliance. So building technology solutions to help in the compliance and regulatory space. So helping kind of shift people away from the manual, more error-prone work so that they can do that higher value work of operationalization and benefit maximization, member engagement. So we're here in the Bay Area. The startup is just getting going, and I've just been diving deeper and deeper into the world of compliance, and it's been amazing. And California is going through a lot of changes, which we'll talk about. So exciting time.
It is. And correct me if I'm wrong, you're health plan focused, right?
Correct.
Okay. So an absolute gem to have on the show. Thank you so much, Marwan. We do really appreciate you. So with that said, could I ask you the rather brazen and maybe broad question of, can you maybe set out what Medicaid looks like in California? You already mentioned it has a specific name. Could you walk us through what this looks like?
Yeah, it's a huge program. And from the very beginning, it's been a program that's been very forward-thinking since it was set up through the Social Security Act, along with all the other states. So California State Medicaid, it's called Medi-Cal. Out of the 40 million or so residents of California, 14 million are enrolled in this program. It's 35% of the population. This is similar to other states, but 1 out of every 2 births, occurs in a Medicaid, Medi-Cal setting for children. Lots of kids, lots of moms, and we have a rich history of waivers, and we can talk a little bit more about this, but it's basically this idea that we really want to do as much as we can, as much as we're capable of doing, because we have such an enormous population and we have such a huge demographically diverse population. And so it necessitates that kind of innovation. And it's been a fascinating part of that is that it's been largely bipartisan. It's not a partisan issue, even through periods of time where we had different political parties, one thing has always remained constant, which is to innovate in this Medicaid space.
Okay, so I mean, what's the regular structure? What's the regulatory structure? So first of all, how is Medicaid in California administered?
Yeah, so we have the Department of Healthcare Services. California is, regulated in a lot of ways for health insurance.
Okay.
You can think of it from a state perspective in two ways. The commercial health plans, which are regulated by the Department of Managed Healthcare, DMHC.
Okay.
And then our side on the Medicaid side, the Medi-Cal side, is administered or regulated by the Department of Healthcare Services, DHCS. So they're the ones that will write all the plan letters and spell out the benefits, and are largely responsible for administrating the program.
Okay.
And then it's heavily managed care. So there are two ways you can do Medicaid across the country. You can get it straight from the state, or you can have the state delegate that to a lot of health insurance companies. And in California, it's very largely delegated. So over, 95, 96% of California recipients of Medi-Cal will be in a delegated model. In other words, they are getting their benefits via a health insurer of some kind.
Okay, so as a provider, if you wanted to offer services in California, you'd enroll with the managed care organization and not necessarily directly with the state?
Yeah, as a provider, sure. Yeah, as a doctor, let's say your clinic and you want to take Medi-Cal patients, you would be enrolling in that program that's administered, at least on the policy side, on the Medi-Cal side for with DHCS, and everything else on the clinical side is the usual NCQA, Joint Commission, so on. Yeah.
Okay, so you mentioned, I don't know, I have so many questions here.
Great.
I'm interested, first of all, in who's responsible for, let's say, the regulatory activity. So if you have the state and you have these managed care organizations, and so much is delegated to the managed care organizations, what does that regulatory landscape look like? Like, who does the checking?
Yeah, great question. So we'll take a quick step back, and of course this is rudimentary to you all, but maybe to some people in the audience, just a little bit about the way Medicaid is kind of set up. And it can be sometimes a little confusing because people think of Medicare pretty often, because Medicare is that large program for the elderly typically, and it's federal. But Medicaid can be a little bit more complex. So maybe just quick high level on that.
Yes.
So when Medicare and Medicaid was first created, and it was pushed out in 1965 by the Johnson administration, it was really actually kind of controversial to spend all this money on people's health care. And sort of as a negotiating tactic, what the federal government did in order to be able to make it sort of work, the numbers work from a federal perspective, was say, hey, look, we'll pay for Medicare, which is why the Medicare side is always going to be that national program. But the states said, look, why don't we do it so that we'll do 50%. So if we put in $1, the federal government will put in $1. And if we follow certain rules, that dollar will qualify, and we'll submit documentation and we'll show what we're doing. And if it qualifies and we put in $1, the federal government will give that dollar in as well. So it's matched. It's a matching program.
Okay.
So in California, there was an agency that existed before actually the Department of Healthcare Services that had a different name. But when we started that program, the Department of Healthcare Services became the holder of the dollars, the conduit of the dollars, and the main administrative body that said, this is what our program is going to look like. And the way they disseminate what I just said, how it looks like, is through these things called all plan letters, APLs for short, which are basically these decrees that go into the system and say to a health insurance company, or to say a county even, this is what Medi-Cal is going to be providing beneficiaries. And in doing so, they also become the regulatory agency that will do the audits. So to your question, who oversees it? The Department of Healthcare Services has auditors. They come At the plans I was at, they came every single year. They would come sometimes even during COVID, they would be on site, and they would look at every little thing. We're talking about medical record review. We talk about the authorizations. They would look at claims, and they go into every little thing, and they choose typically an area they want to audit, either because they know it to be an area of particular risk, or maybe because they've heard some complaints. Maybe there's a budgetary aspect of it, and they're concerned that certain things might not be functioning the way they want to be. They want functioning from a budget perspective. They'll choose that portfolio of things, and then they'll go in and they'll audit health plans to those things.
I've heard that those audits are really very rigorous. I mean, California in general. I'm not trying to step on any toes. It's just what I've heard being on the opposite side of the country, that actually the regulatory space within California is really quite robust, and that they are very, and working with clients. I have clients in California, and from what I can see is that when you get audited in California as a Medicaid program, it's tough. I mean, it's tough anywhere. I've been through Medicaid audits and program reviews across states, but California seems particularly, I don't know how to describe it, only robust and thorough might be the word I'm looking for. Were you going to ask something, Elvan?
No, I'm listening, so I can ask.
That's all right. That's all right. So, I mean, I'm just wondering, in your experience, is that process particularly different from other states? Like, really, how tough is it?
Yeah, it's a great question. Actually, I'd be really curious. It's just because my experience is so California based. I'd actually be curious what it must be like to sit in audits in, say, New York or Texas, other states that I know have very rigorous programs. I will say this: it's a true statement. The Department of Healthcare Services are very thorough. They're all very intentional. They want to work with health plans. It's interesting. One thing that I found from sitting in so many and doing so many audits, I'm typically the one who's I've led teams in health services. Health services is arguably the most audited part of the regulatory part of healthcare, just the healthcare part. And I've always sat over health services. So that's utilization management, care management, behavioral health, things like that. And to your point, the rigor that you're speaking to is that they're very detail oriented. I'll give you an example. We'll be at a table with DHCS, Department of Healthcare Services. This is the Medi-Cal agency. And we'll have a computer screen up, and they will literally say, okay, walk us through this denial. So in a way, they're not, yelling at us. They're not berating us. But what they're doing is they're saying, show me everything you just did on this denial.
Yeah.
Which is inherently a very intense situation, because you're like, okay, I better hope we wrote the note right. I hope that the letter went out perfectly. I hope that everything was effectuated in the system. So you're right. I think the part that's rigorous is that they're very meticulous. So that's the one thing. The other thing I'll say is, and this is a bit of an ancillary part of this, most health plans are also licensed. It's called a Knox-Keene license. They're also licensed to offer insurance products in the commercial market. And as I said before, there's a bifurcation in the state of California. The DMHC regulates the commercial piece, and DHCS regulates the Medi-Cal piece. Well, it just so happens that a lot of times they synchronize their audits to occur at the same time. And for instance, I know of a plan I worked at previously that's, I think, literally this week. You sit at a table, and on one side you'll have DMHC, literally, and the other side you'll have DHCS, and they'll be auditing you at the same time.
And I haven't seen that. I do think that's different from what I've seen in other states.
Yeah.
Without any
What
doubt.
is the benefit?
Absolutely.
Yeah.
What is the benefit of that?
Great question.
What is the benefit of that?
Yeah. So each of them needs to tick and tie their own set of boxes, right? Their own set of boxes. Now, the benefit to the state is that in one shot, they can get the commercial side taken care of for that plan and the Medi-Cal side taken care of that plan, kind of in one shot. And they can kind of piggyback on each other's questions, because there are certain things, whether you're in commercial or Medi-Cal, that are pretty universal and overlapping. Things like turnaround times, for instance. Things like access and availability, right? These are these kind of bread and butter regulatory things. And so it's kind of a bang for their buck. They can kind of, I noticed when I was in one of those where they were on two sides, they would be playing off each other. And they would say, oh yeah, tell us a little bit more about that transportation piece, or tell us a little bit more about that provider letter piece. What do you do to confirm that the provider letter was actually sent? What do you do when it doesn't go through? So they kind of are building off of each other.
Yeah, I do think that's quite
I don't see
unusual.
a benefit there.
It's intense.
See the
So
benefit.
okay, so
Benefit to the state. No,
I'm glad that you're bringing this up.
up.
It's great that you're bringing this up, because I try to always assume the best intentions. The hardest part about it, though, as a managed care plan in California, dealing with the regulatory environment, is that in any given year you could have NCQA being accredited or recertified. You could get your Medicare audit, because if you're running a duals program, you have to be audited by Medicare. You're going to definitely get your DMHC audit, and you're definitely going to get your DHCS audit. CMS will audit, when they do audit, they audit your model of care, which is your process, but they also do your risk adjustment data validation audit for risk adjustment. So you have created the world we live in, the system we've all built together. I feel like I'm part of the system, so I will take responsibility. We are in a perpetual state of audit in the state of California. Perpetual state of audit.
Okay.
so it's not a one and done kind of thing.
You're never done.
How do you manage that?
Oh,
Sorry, Elvan, did you have a question? Was it your same question?
That's a good question for Jessica. And how do you manage that? And where do you see the truth? Because ultimately, we have regulations out there to benefit the beneficiaries. I have to believe that, just like you assume good intent. That's what I always assume. Is that why do we have a regulation? Regulation is there to protect you, me, and everyone who may be using the system one day. So, okay, what is the benefit to them? Because when we start doing check marks for the check mark's sake, and creating paperwork to create just the jobs but not a solution, we have a problem usually.
Oh, so much here. I'm going to try to be fair.
Sorry.
I'm going to try to be a fair. This is such. Oh no, I love it. I love that you all are pushing, because I can sometimes be the one pushing, and I want to be careful because I want to respect the tenor of your podcast. So I do think that. Look, California's, just really quickly, California, remember when we were talking about how California, in all state Medicaid programs, you have to put in your dollar, and then the federal government will put in their dollar?
Yeah.
Well, you have to qualify. That dollar has to qualify. I can't just pay for anything. In the state of California, if I said all of a sudden, I want to make red sweaters a benefit, I want everybody to get a red sweater who has Medi-Cal. The state might be great. We're all in favor of that. Red sweaters are super important. It's going to make everybody healthy. Well, the federal government who's matching that dollar might say, oh, wait a minute. Red sweaters, we're not so sure about the red sweater
thinking
thing.
more like a burgundy.
More thinking burgundy. Exactly, right? Okay. So this is where the question around the waivers, because the waivers, the compliance, the scrutiny, and then to your point, the value, it all cascades. It all relates. So really, really briefly, if I'm a state, any state, if I'm a state that wants to do something that isn't traditional healthcare in that medical model sense, and what I mean by that, going to see a doctor, going to get an MRI, getting a prescription. If I want to do anything that kind of veers off a little bit, things like transportation, medically tailored meals, I have to ask the federal government, hey, if I do this, will you let this qualify for that dollar that I kind of said I was going to put in and that you said you were going to put in? Will you let me do that? That actual request is called a waiver, and it's in order to waive the normal traditional constraints. Can you waive that for me? Well, why would you want me to waive that for you? What's the deal? Well, we think meals would be really good for people like diabetics or post-stroke, post-myocardial infarction. We think that could be really helpful. Oh, really? You think? Yeah, we do. There's some data to support that. Okay, why don't you go ahead and do a pilot program? Okay, we'll do that. Let's, 5 years? I'm describing something that's currently happening now. So, oh, okay, 5 years. We'll give you 5 years. Go ahead and do that. You can. What do you want to supply? Let's do transportation. Let's do some. Maybe you can help people with housing. Okay, cool. That's good with you. Great. And they just kind of throw a bunch of stuff out there. The federal government then goes back. They consider it and they come back and say, okay, you're approved. Well, now on some level, the state needs to be held accountable by the federal government. So they're going to get. They're going to.
Yeah, that makes
Exactly.
sense.
Exactly. They're going to get audited. Well, the nature of politics, the nature of relationships in general is, well, if I'm going to be held accountable by these people are going to be accountable to me because I need to know, because DHCS, right, the state of California's the Medi-Cal agency, they can't do it themselves. There are 26 managed care plans that are doing Medi-Cal on their behalf in a way. Yeah. So they have to go. So to answer your question, I believe the intent is for transparency and to prove efficacy, to be responsible from a budgetary perspective, and to genuinely try to move the needle on homelessness, food insecurity, housing insecurity. I really do believe that. Again, I could be idealistic. I do believe that the intent starts there. But where it ends up, I think might be a little of a different story.
And I think it matters which side of the fence you're on. Having worked for a regulator and been on that fence, there is an idea of, okay, well, if we're auditing together, if we're assessing together, that's maybe it actually, although it feels very stressful to the health plan, actually, maybe we're more coordinated. We use fewer resources. We overall impose less rather than having separate audits, pulling people away from patient care more than once. We do it together. It's going to be stressful no matter what. But if we can coordinate our audits, because I've worked in environments where the audits aren't coordinated at all. And a lot of them are asking the same questions, looking at the same things. So you are constantly pulling people away from their work. And I wonder if part of the idea is actually an effort to make the audits more efficient and less costly for both sides. That's certainly what was maybe bred into me again and again, being very conscious that we are working in healthcare. Whenever we pull people out, it means other people aren't maybe getting patient care or clinical care, and really thinking hard about how you minimize your impact, knowing that you have a job to do as a regulator, as an auditor, but appreciating that every time you get in front of these people to do your job and to make sure that the quality of patient care is good, on the other side, that means you might also be taking away from patient care. And there's also how much government money are you using? So there's to conduct this audit and this oversight. And that was always drilled into me, those two things. Hey, we're using taxpayer money to do these audits, so it better be very efficient. It better be very thorough. And on the other side of it, every minute that we take these people away is a minute that, someone's not getting the care they need. So I think there's a big tension there, right? And maybe no one great way of doing it. Elvan?
This is my pet peeve. I love me some sunshine. That's where my relationship with my birth state ends, as in California. It's just too complicated. It's just too complicated.
But maybe that's the nature of the healthcare system. And that kind of leads very nicely to my next question. California has some like any state in any area, has some very specific challenges. And also, California is known for having a very specific set of values and priorities. Marwan, are you able to talk to us about some of those priorities? So I know from my own just living and my own curiosity, but also from talking to you as we were prepping. You talked about things like housing, care navigation, a focus on justice, and you don't always see those as health priorities in other states. But could you talk to us a bit about the priorities that the state has?
Yeah. Yeah, that's a great question. I think, hold on to your point around the complexity is I agree that one thing we could also do better is to simplify things. So let's talk a little bit about what the general flavor of what California's attitude has been towards the state program, Medicaid program, Medi-Cal, ever since the beginning, from when it was first created in the 60s, and then it shifted to managed care in the 80s and 90s, managed care being that it's delegated to these health insurance companies instead of the state directly doing it. And then, boom, right away, I think 1990, 1991, immediately a waiver was already created, and then a series of waivers. So California, I think because it struggled, it's like a mini country.
Yes.
It's 40, it's 40 million people. It's like running half the size of Germany.
Yeah.
It's a huge country with some of the most socioeconomically disparate areas. We have areas and counties here that have no hospitals at all. There was a county I was working in to administer Medi-Cal recently, a county that had one ear, nose, and throat doctor. One. Right?
Oh, wow.
Yeah. And so you had patients who had to drive all the way from that county into the Bay Area to get care if they needed an ENT. So one of the things right off the bat, to answer your question directly, Jessica, is appreciating early what we are now all calling the social drivers of health or social determinants of health.
Yeah.
And what that is just the non-traditional, non-conventional inputs and influencers of your health. What I mean by that are things like asthma and living near a highway. No one would ever think that if you lived near a highway, you would have higher prevalence of pediatric asthma. Lo and behold, you do. Well, how do you remediate that? Well, that housing is typically housing that is for lower socioeconomic strata, people who are poorer, and those houses and those accommodations are typically poorly built. So one example of a remediation is to help fortify the windows. I mean, that is a crazy way of thinking about treating asthma. Of course, you also want things like inhalers, albuterol and corticosteroids. You also want regular wellness checks. You also want smoking cessation. There are a lot of other things. But one of the things that California sees and activates and effectuates are these things that you wouldn't normally think would make an impact. And in doing so, have been able to shave off a good amount of dollars. And they've been able to improve overall health of populations. So I'd say, to answer your question the most directly, I'd say, Jessica, the single biggest kind of innovation would be in amping up that social determinant space.
And I mean, it makes sense as we talk about some of the solutions, but I think the point is we don't naturally, as a society, we don't naturally gravitate and think, I mean, addressing social determinants of health requires thinking outside the traditional box that we think of as healthcare. It really does. It's a step outside and making that connection. And I get the sense that California is ahead of the game than some of the other states in the country. I'm interested in really picking your brain around this idea of justice and what that means. Because in working with my California clients, I see more of that. In fact, I don't see that with any of my other states. I don't see that focus. Could you talk to us? What is it, first of all?
Yeah, great.
And why, what's happening here?
Great. Okay, so it's such a loaded word because in a lot of ways it becomes so kind of based in your politics. So let's stay away from that for 1 minute, and then we can come back to it. Let's start with just the justice involved people who are in the justice system. These are people who have been incarcerated and who are going to be released. These are people who hadn't had any healthcare really while they were incarcerated, probably had pretty spotty healthcare before they were incarcerated, and now they're being released. A lot of them have healthcare needs. So a very defined, clear program is actually a county and health plan collaboration for health plans to go in and work with incarcerated individuals pre-release to get them set up on Medi-Cal so that they have coverage, even get them a primary care physician so that they have somebody to see if they need to go and get the health thing kind of taken care of, so that they can go get a job, so they can go get housing, so they can kind of right size their lives and hopefully be, contributing to society. So from a very kind of just defined standpoint, whether you're left or right or middle or whatever, it's simply getting healthcare for people who are leaving that incarceration. And that's called...
That's right. It's not a political issue on this podcast. It's more about it is there. What is it? Yeah.
Yeah, and it's that allowing us finally to go in and saying, hey, you're going to be released in 90 days. What are you going to do with healthcare? I don't know. Well, what do you have? What are the things that you suffer from? And of course, it all plays into like, well, the people who are typically incarcerated the most are people of less means. People of less means typically have had poor healthcare throughout their lives, starting with prenatal healthcare because their moms probably didn't get the healthcare they needed. So they have higher prevalence and higher rates of disease. Their disease burden is just higher. And so they're leaving incarceration without any resources, and it just confounds and increases the rates of recidivism because they're not able to get their jobs and they're not able to take care of themselves. So that's one side. It's called justice involved. It's literally like money that can be spent to help people who are transitioning from being incarcerated back into civil society. That's one side. There's another side to this, which is more of a structural thing, which we can probably define best as structural inequality. And it goes something like this. I mentioned before that there are two agencies that regulate health insurance in the state of California. DMHC, which is the commercial side, and DHCS, which is the Medi-Cal side, the Medicaid side. Now, they can choose to cover different things because they are different agencies. They work with different dollars. Recently, the commercial side of this, the DMHC, decided that they are going to make standard IVF fertility treatments for people who have commercial insurance. The reason why is extensive, but a lot of that is because commercial insurance is paid for by commercial payers. Commercial payers can typically afford richer benefits, and those are typically for people who are employed. So now you have a situation where the commercially insured population has, as a benefit, their insurance company have to cover certain amounts of IVF treatment for their population. So if I'm an employed Californian and I have commercial insurance here, I have a certain amount of IVF benefit. Great. DHCS couldn't pass that same benefit. They couldn't. They didn't have the money to. It's expensive. So I think it came down to money. So they didn't pass that. So if you're a Medi-Cal recipient, you don't get IVF covered. Okay, so the intent is to cover IVF. Great. But what is going to happen now is people who are well-resourced get IVF. They're allowed to have more kids in the IVF setting, right? But DHCS, the Medi-Cal recipients, don't. So it's a really good example of how the intent is to cover IVF. Great. I mean, absolutely. But you're also creating a structural inequality over time because people who have Medi-Cal don't get it. People who have commercial insurance do. And it goes like this. The graph will go like this. And so it's just an example. Justice involved in an incarceration sense, but then social justice in the structural inequality sense.
Yeah, and I that's a great explanation of it. And you were telling me about it, and I was fascinated because I had to learn what the justice involved component of the Medicaid program in California was, because I hadn't seen it before. So it's something, I think, I might be wrong, I don't know all 50 states, but I think it's something that's unique to California.
Mhm.
So we talked a bit, and you started to get there, about how the regulatory space in California is changing, or the healthcare regulatory space is changing. Do you want to talk to us a little bit about what the changes are that you're seeing and maybe why that's important?
Yeah, absolutely. So a couple of controversial things. California, for instance, passed some legislation to cover undocumented people. A little under 1 million people who are undocumented residents of California. Look, whatever your politics are, these people have babies. These people go into the hospital. They go into the ER.
Correct.
So
They're there.
Yeah, they're there. I mean, like, you can be on whatever side you want to be on, but if you don't have insurance for them, guess who eats that bill? The hospital. And guess who the hospital passes that cost to? An insurance company. And guess who the insurance company then passes the cost to? You. So there is no getting out of this. If you don't give on some level, if we have people here, then we need to give them on some level a certain amount of care. So one thing that we're struggling through right now is, how do we make the numbers work? Because that dollar, remember, we're talking about matching dollars, that dollar is definitely not going to be given back to us in the current federal climate.
It's not going to be matched.
It's not going to be matched.
In the usual way, yeah.
So California right now needs to decide whether or not they're going to continue paying for it themselves, because any state can pay for whatever they want out of their own dollars. If they don't even go to the federal government for the match, hey, go ahead, red sweater it up if you want, as many red sweaters as you want. In this case, undocumented, sure, go ahead and cover them. We're not going to give you the money from that federal perspective. So that's the first thing. That's a lot of money. It's on the order of 12 to 15 to 20 billion dollars. It's a lot.
Yeah.
$150 billion program for Medi-Cal. So the second thing is this thing called CalAIM. So California, again, in its rich history of waivers to address social determinants, submitted a waiver 5 years ago to say, hey, we want to cover all these things that we were talking about before that are non-traditional drivers of health. We submitted that waiver 5 years ago, and it's up for renewal, I think, at the end of this year. This year is literally the last year. Remember when I said how the federal government will say, okay, we're cool with this. We'll give you 5 years. Well, now we have to prove efficacy. We have to show, well, you guys got 5 years to cover housing and meals and transportation and long-term care and all this stuff. And we said we would give you money for it. What's the deal? What's going on? Is it working? Because we're not just going to give you endless amounts of money for no efficacy here. And so right now, that's in the process of getting renewed. There's a lot of controversy around what will be renewed. We think some things will be renewed around it. We're just not sure what. That happens literally this year. I think as of today, they're in a comment period. That's the second thing. The third thing is all the health plans in California, essentially, if you're a managed care plan, if you're a health insurance company in California, you have to be NCQA certified and NCQA accredited. Have to be. It's not a choice. And maybe a separate episode for what NCQA is, but that's basically that stamp that says, hey, you are a high-performing, high-quality healthcare organization. So that has to happen this year. It's part of the contract that the health plan has with the state. And then the last thing is duals. So you can have Medicaid and you can have Medicare. If you are very, very sick, and if you hit certain income thresholds, or if you're old and you hit certain income thresholds, you can get both benefits, Medi-Cal and Medicare. And that's called a dual eligible beneficiary. Dually eligible for two things. And the health plan has to have a dual eligible program, and those programs are called DSNPs, Dual Special Needs Plan. That has to happen this year and going into next year as well. So it's all this stuff that's getting added more, and you can bet that some of it is going to go nationwide. That over time, Anyone who's a health insurance company who isn't NCQA certified better get going now. And if you're not going to launch, if you haven't launched a DSNP yet, yeah, I would start doing the modeling now because that's going to happen.
I think we are seeing some of that and it's happening. But a question for you. So this is a lot. There's so much happening in California. I mean, that's kind of the model for other states to be watching in terms of how you deal with so many stressors, right? And challenges. So you have these health plans, these health insurance companies. I'm interested in understanding, how do they do all of this work? So obviously you have a health plan, they can't possibly do it by themselves. Do they enlist different agencies? Like, how does this work happen? So I know other health plans in other states, they'll enlist the help of community groups.
Yes.
And you'll get, not just your normal hospitals or your providers or your healthcare providers, but they will get involved with community groups and other agencies and not-for-profits to look at ways of engaging the public and maybe harder to reach individuals and kind of bring them into the healthcare system in one way or the other, whether that's to help with care and navigation or homelessness or whatever it is, whatever the needs are. In your experience, is that how it works with health plans? Like,
absolutely. Yeah, no, so it's such a good question because I want to figure out how to assign the right help to the right folks. So let's start with counties. So, because California has a really strong county system, like the counties themselves take on a lot for housing navigation, for transition from incarceration, meals, homelessness. A lot of these programs, I think counties don't get enough credit for trying to do as much as they can and then working with the health plans in their catchment area. So it starts with the counties. The counties then move, to your point, to these community-based organizations, CBOs, that do a lot of the actual ground game, actually boots on the ground, engaging with people. Yep. And we have rich, both financially and in talent and in resources and human power. The academic centers here are incredibly strong. We wouldn't have a fraction of the ability to do what we needed to do without, say, UCSF, University of California, San Francisco, or the UC system. So I think that fabric is really unique in this area. I will say one thing though, it's heartbreaking to see the disparity here between well-resourced counties and well-resourced areas within counties and the rural areas. And now I live in the Bay Area. We have the best healthcare arguably in the world, like right around. I've got Stanford, I have UCSF, I have Sutter, I have Dignity, I have all these amazing places around us. But you go over not very far. 2 hours east of here in a county like Merced, which is where I worked at before. They don't have anywhere near the concentration of resources. It's heartbreaking.
So, but that kind of connects to my next question. Like, what's the relationship between the managed care organization and the counties? Like, to the managed care organizations, there's no planning. On one level, I understand how that happens. On another level, I don't. I'm wondering, is there a level of planning that I'm missing here? Or maybe I'm naive and my expectations are not based in reality. Like, how do the counties know what they're doing and how they're targeting? Is that dictated by the Medicaid program or by the health plans? Like, how does that happen?
Yeah, it's such a timely question, because one of the components of CalAIM is to increase the amount of connectivity and collaboration between counties and health plans. Like, we were asked to actually draw up and fully execute memorandums of understanding, these contracts essentially between counties and health plans to share data, to do care management together, to collaborate, essentially to work more closely together, to do things like enroll members into certain programs and to pay for certain things, money that would flow from the state through a health plan and then into the county. So that's really new. It's a really good question. And I think it's one of the biggest struggles. A good example of that is substance use disorder, alcohol use disorder, and mental illness, mental health care. It's all very siloed. Health plans, the Medi-Cal plans, we are accountable for mild mental health services, mild to moderate mental health services. But severe mental health gets carved out, and that goes to state and county is basically accountable for that, county services. So that's a really tricky one. When somebody is, say, for instance, migrating from mild to moderate into severe, that's a really tricky point where counties and health plans have to be collaborating, and we have struggled. Technology, there aren't very many good technology tools for us to be using to enhance that collaboration. It's really difficult. It's one of the hardest things, Jessica, is that county to health plan collaboration.
Okay. So the counties aren't necessarily, it's not the right word, but they're not beholden. They're not obligated to the health plans naturally. There has to be a relationship and build up.
Yeah.
I really didn't appreciate that.
Yeah.
I mean, I don't know that that's any different from any other state, but certainly for California, I did not appreciate that. So you mentioned carve-outs, Marwan. Can you talk to us a little bit about what is carved out?
Yeah.
I'm still struggling between, and I don't know why, it's something about me, I get that, between Cal-AIM and Medi-Cal. I'm still...
Yeah.
I'm getting it wrong.
No, we can definitely talk and clarify that a little bit more. So carve-outs generally, just for the general idea, is it's services that the health plan, that the health insurance company are not covering, that are still benefits to members, but they're just being covered by other entities, so either counties or state. And a lot of that is money. It's just money. Because in a perfect world, you would have a one-stop shop, one place where you can get your dental care, where you can get your mental health care, you can get your substance use disorder care, you can get everything all in one spot. The issue with that is it just becomes incredibly expensive, and then politics starts to take hold. So a good example of that in the state of California is that managed care health plans used to administer drugs, used to administer pay for drugs, pharmacy benefit. But Gavin Newsom came in and said, hey, look, I want to be able to negotiate drug prices from the standpoint of being in California and do it from Sacramento, centralized. I want to be able to negotiate them myself. The only way I can do that is if I bring the pharmacy benefit back to me.
That's right.
So he carved it out, took it back, so that he can then now use his leverage as the largest, the most resource state, to then negotiate with drug makers on certain drugs. So that got carved out. But I would say, Jessica, largely it is a political and process and administrative issue to carve things out, less than it is, or more than it is, an actual benefit to a member to have it carved out. It doesn't benefit members at all to have things carved out. Makes it more complicated.
It does, but one might argue it reduces prices. Arguably, I don't know that that's a fact. I'm just saying the theory is.
Yeah, we'll see. I'm curious to know if drug prices, due to the carve out, were better. The prices themselves, the unit cost might come down, but if things like adherence goes down too, because customer service and care management isn't rolled into the health plan anymore, then it's like, okay, unit cost came down, but then fewer people are taking their medication.
Yeah. No, that's out. You don't know, you might save a few pennies in one place, but the consequence might be greater. All right. we're getting to the end of our episode. Elvan, were there any questions you wanted to ask? Because I kind of hogged
No,
the
this has been,
questioning.
again, hugely informative. I think this is, as you said, things get more complicated the larger population it covers. So that makes sense. It just seems like the more you explain, the more I was like, well, why would anybody ever want to do what they do in healthcare in California? It just seemed a little overwhelming. I'm not going to lie. I'm like, within the acronym soup, I was like, I wrote down a few to be able to look up and learn, and I was just like, you're never moving there. There's a reason for that. You moved out of there. There's a reason for that. It's like it seems, again, I'm trying to have a hard time really reconciliating in my head as to how this benefits the patient. Compliance is there to benefit the patient. I am having a hard time.
And I
seeing it.
guess I'm
having a hard
taking
time.
I've taken the opposite view. Whereas I'm like, yeah, I get the complexity, but I understand why it's there. Like, I understand what's happening. Do I think all parts of the system work beautifully? No, but then I can look around me. I don't need to go to California to say that. I mean, I can say that of,
You're right.
every state or every organization or any program. I don't know anything that works perfectly. And I'm really intrigued, if I'm honest, by the policy behind what's happening in California. And I'm intrigued because it is so complex. How do you make that kind of system work? And I'm not saying that, I'm not commenting on the merits of it, good or bad. I'm just saying I understand there's the state's identified a particular set of needs, a particular set of challenges, and has taken the steps to try and address them. And I think there's an inherent complication there. There are inherent challenges. That's the point. And maybe sometimes if you're trying to do something well, it isn't easy to do. And if you've got a set of particular challenges, well, that makes things even harder. And I guess I'm fascinated by the process and how it works. It's an experiment. Will it work? How does it work? I mean, other countries manage to do, and this, they try to address the same issues in a very similar way, right? And some parts work. It's not always an advantage to the patient, but you're trying to weigh up advantages, different advantages and different disadvantages, and trying to come up, I guess, with the solution that says, okay, we accept things aren't going to be perfect, but this is the best that we've got.
We can do. Yep.
Yeah. And so I'm interested. I mean, I'm really intrigued as a compliance professional. Like, how does it work? And someone who's interested in policy. So for me, this is amazing. And we'll just have to see how the experiment pans out.
Well
Was
said.
there anything, Marwan, that you wanted to address on this podcast before we go?
No, this was great. Thank you so much. I love talking about healthcare, and California's, like you said, such a crazy place to do it, and it's been fun to do it. I look forward to many more years doing California healthcare. So I'll deal with it so that you all don't have to deal with it. How about that?
Fantastic. Then we'll invite you again so you can talk about it. So
Perfect.
We don't have to.
I love it.
Elvan was the one who said she didn't want to deal with it. I said it was fascinating. How did you
I
today?
don't. I really don't. I don't.
Oh, well, then you'll have to offer us some moral support. You'll be there cheerleading on the sidelines
You're right. I should.
from Michigan.
Frankly, I really
guys.
would love to have Marwan again to dig deep on some of the things that I'll be looking into. I mean, I don't know what you say, Jessica, but I think it's a big subject. I think it affects a lot of people, and I think it really does highlight the discrepancies that we have as a country, and how much, just like the conversation we had with Denise, how much geography, resources, money, politics, it just plays such a big part in regulation
Absolutely.
and application of healthcare. And I think that's a beautiful place to leave this conversation, but hopefully come back to it at a later time.
Brace yourself, Marwan. And we were talking about that, Elvan. We were thinking of a part 2. So we'll plan it out and we'll work it out what we're going to say. And on that note, hey, you guys, thank you so much. Marwan, thank you. You did brilliantly. It was really an interesting podcast. Elvan, thank you for being there for me again. I really appreciate it. And we're going to love you guys and leave you, and we'll see you on the next episode.